Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Welcome to the Deep Dive. We cut through the noise, get straight to the insights. Today, we're diving into something huge. It touches, over 15% of the world's population? It's migraine, recognized as the second most disabling disease globally. And here's the kicker, it hits women way harder, like 2 to 4 times more common, especially during reproductive years. Now, for a long time, managing migraine was, tough, kind of repurposed drugs. But then, things really changed with these CGRP-targeted therapies. That's calcitonin gene-related peptide. You've got the monoclonal antibodies, the MABs, and these smaller molecules, Gepants. Game changers, really. So, our mission today, do these breakthroughs work the same for everyone, men, women? Or is there something surprising in the data? We've gone through a ton of preclinical stuff, clinical trials, the whole review. We're aiming to give you the full picture. Okay, so let's start by really unpacking the sex difference in migraine. It's not just more common in women, is it?
No, not at all. It's also significantly more severe for women.
How so?
Well, women consistently report attacks that are, more frequent, they last longer, they're more intense, plus more of the associated symptoms. Things like extreme sensitivity to light, photophobia,
right,
and sound, phonophobia, and more nausea, too.
And that impacts daily life more.
Massively. Disability scores like MIDAS that measures how much migraine messes with your day-to-day, they're significantly higher in women. Women carry, an estimated 79% of the total migraine disease burden.
79%, wow.
Yeah.
And you said this isn't from birth, it changes over time.
Exactly. It really kicks in sharply after menarche, when menstruation starts, and then it tends to lessen quite a bit after menopause.
That timing, it points pretty strongly towards hormones, doesn't it?
Absolutely. Fluctuating sex hormones seem to be a major player. And what's truly fascinating here is how central CGRP, that's calcitonin gene-related peptide, is to all this.
Okay, tell us about CGRP.
All right, so think of CGRP as a key chemical messenger in the migraine process. During an attack, it gets released from activated trigeminal nerves. Those are the main sensory nerves in your head and face. And this release, it triggers stuff like blood vessel dilation, neurogenic inflammation, basically things that drive the pain.
So the anti-CGRP therapies just block that?
Precisely. They're designed to shut down that CGRP pathway, interrupting the pain signal.
Okay, so connect CGRP back to the hormones then. How does that work?
Well, there's this idea called the estrogen withdrawal hypothesis. It suggests that a rapid drop in estrogen, like what happens right before menstruation, can be a really powerful migraine trigger for a lot of women.
Oh, yeah.
And conversely, when estrogen levels are stable and high, like during pregnancy, many women actually experience remission, fewer migraines.
Interesting.
And crucially, we actually find estrogen receptors on those trigeminal nerve cells, the ones releasing CGRP.
So there's a direct physical link.
Exactly. A direct anatomical pathway for hormones to influence the migraine machinery. And the evidence for this is pretty compelling. Animal studies show baseline sex differences in CGRP levels and how sensitive they are to it. Like, if you apply CGRP to the dura, that membrane covering the brain in rodents, it causes pain behavior in females, but not males.
Really? Just females?
Yeah, it's suggesting they're sort of primed, more sensitive, and human studies back this up too. Women tend to have higher CGRP levels during their period when estrogen is low compared to controls.
So low estrogen seems linked to a more active CGRP system.
That's what the data points towards, yeah.
So if hormones are tweaking the CGRP system like that, does it go deeper? Like, are the fundamental pain pathways themselves just different between men and women?
That's a great question, and it brings us to this broader concept called sexual dimorphism in nociceptive pathway.
Okay. What does that mean in simple terms?
It just means there might be fundamental built-in differences between the sexes in how our pain systems are wired and how they function. Not just how we feel pain, but maybe how it's maintained, how chronic pain develops. So yeah, putting all that biology together, the hormones, the CGRP link, potential pathway differences, it makes it totally plausible that therapies targeting CGRP might not work exactly the same way in men and women, especially with that hormonal factor in females.
Right, that makes sense. So let's get to the treatments themselves. Did these revolutionary CGRP therapies manage to overcome these differences? Or do we see sex-specific effects there too? Let's start with the first class. The monoclonal antibodies, the MABs, you mentioned erinumab, femidizumab.
Galcanezumab, eptinezumab, yeah. Those are the main ones.
What are these exactly? How do they work?
Okay, so these are large protein molecules, big molecules. They stick around in your body for quite a while. Their half-lives are like 27 to 39 days.
Which means less frequent dosing.
Exactly. Usually just once a month or sometimes even every 3 months, which is great for adherence. And importantly, they don't easily cross the blood-brain barrier.
Ah, so they work mostly outside the brain, peripherally.
That's the thinking, yes. Their main action seems to be in the periphery, and they work by either grabbing onto the CGRP molecule itself or blocking its receptor, basically stopping it from causing trouble.
Okay, so the big question for these MABs, when used for preventing migraines, do they work equally well for men and women? What's the overall conclusion?
Well, the news here is actually pretty good and quite consistent. For preventive treatment, these MABs show, robust efficacy, and it seems largely comparable between males and females. Safety, too.
That's really encouraging. Let's dive into the specifics, though. Was it consistent across all 4 drugs?
Remarkably so. Take erinumab. There was a big real-world study, ESTEEM, notably. It had about 18% men participating, which is decent for these studies, and it found erinumab was, and I quote, equally safe and effective in men and women. No statistically significant differences found in reducing migraine days or response rates.
Okay, one down. What about femidizumab?
Similar story. A post-hoc look at the Focus study, this one had about 16.5% men, often with difficult-to-treat migraine. It found consistent and statistically significant reductions in monthly migraine days, and this was regardless of the patient's sex.
Okay, that's 2. Galcanezumab.
For galcanezumab, pharmacokinetic studies, those look at how the drug moves through the body, showed that sex didn't really affect drug exposure in a clinically relevant way.
Meaning men and women got similar levels of the drug.
Essentially, yes. And regulatory documents, real-world studies, they also did not demonstrate any meaningful differences in efficacy or safety between men and women.
And the last one? Eptinezumab.
For eptinezumab, the FDA drug trial snapshots are quite explicit. They state it worked similarly in men and women, and side effects were similar too.
So, summing up the MABs for prevention, we can pretty much expect similar results for everyone using them.
That's what the collective evidence strongly suggests, yes. All 4 point to comparable efficacy and safety for preventive use across sexes. It seems like that sustained, high-level blockade of the CGRP pathway just works really well for prevention, regardless of sex or those hormonal fluctuations. It's a consistent effect.
Okay, that's a fairly straightforward and positive story for the MABs in prevention. But now let's shift to that second class, the small molecule CGRP receptor antagonists, the Gepants, like ubrogepant, ribagepant, caripent.
Davigepant too, yeah.
What makes these different from the MABs, and how are they used?
Well, the big difference is they're small molecules. That means you can typically take them as pills orally.
Which is more convenient for many people than injections.
Definitely. They also have shorter half-lives, so they clear the system faster. And a really key point, they don't cause vasoconstriction, narrowing of blood vessels.
Ah, so safer for people with cardiovascular concerns.
Exactly. That's a significant advantage for certain patients. And they're versatile. They can be used acutely, like take one when a migraine hits, or preventively, often taken daily or every other day.
Okay, so given the consistency we saw with MABs, is the picture for Gepants just as clear-cut? Or is it messier?
This is where it gets definitely more complex and frankly a bit contentious, particularly when we're talking about using them for acute treatment, like stopping an attack that's already started.
All right, let's focus there first then. Acute migraine treatment with Gepants. In the clinical trials, what are they looking for? What are the main goals?
The main goals, the co-primary endpoints, are usually 2 things at the 2-hour mark after taking the drug. First, being completely pain-free. Second, being free from your self-identified most bothersome symptom, or MBS, that could be nausea, light sensitivity, sound sensitivity.
Okay, 2-hour pain freedom and MBS freedom. So what did the data show when they pooled results across different acute Gepant trials? Did men and women respond the same?
This is where we see a really striking difference. A pooled analysis by Porca and colleagues combining data for ubrogepant, rimegepant, and zavegepant in acute treatment showed a significant sex-based disparity. For women, there was a clear benefit, statistically significant, clinically meaningful. The average effect, subtracting the placebo response, was about 9.5% for 2-hour pain freedom.
Okay, 9.5% benefit over placebo for women.
Right, which gives you a number needed to treat, or NNT, of around 11. That's generally considered pretty good. MBS freedom was also significant for women.
And what about for men in that same pooled analysis?
That's the contrast.
Yeah.
For men, the pooled data actually failed to show a statistically significant benefit for 2-hour pain freedom. The average effect was only 2.8% over placebo.
Only 2.8%.
Yeah, and that difference wasn't statistically significant from 0. The NNT balloons up to 36.
NNT of 36.
Yeah.
That's generally not seen as clinically meaningful, right?
Correct. And freedom from the most bothersome symptom also failed to reach statistical significance in men in that analysis.
Wow. Okay, that is a stark difference.
Yeah.
If we try to connect that back to the biology we discussed, the hormones, the CGRP sensitivity, does this finding make sense?
It actually aligns quite well with the biology, you know? If you think about it, an acute therapy aimed at blocking a CGRP surge. Well, if that surge is partly driven or amplified by hormonal factors in women, like estrogen withdrawal,
Then blocking it would logically have a bigger impact in women.
exactly, you'd expect a more pronounced effect. In men who don't have those same cyclical hormonal influences on the CGRP system, it's plausible that other neurotransmitters or pathways might play a relatively larger role in triggering an acute attack.
So the CGRP pathway might just be less dominant during an acute attack in men, leading to a blunted effect from the Gepant.
That's a reasonable hypothesis based on this data, yes.
Now, hold on. I feel like I've seen conflicting stuff elsewhere. Maybe FDA documents or some surveys saying efficacy looked similar. How do we square that with this pooled analysis showing such a big difference? It raises the question for listeners, which data do we trust?
That's an absolutely crucial point, and it highlights a major challenge in interpreting clinical trial data. The issue is that most of the individual trials for these Gepants had very, very few male participants. We're talking maybe 10–15% of the total group.
So small numbers of men in each study.
Exactly. And with such small numbers, the individual trials often lack the statistical power to reliably detect a true difference between the drug and placebo, specifically in men, even if one exists.
So they might just conclude no difference found because they couldn't measure it properly.
Precisely. It's a high risk of a false negative. No difference found is absolutely not the same as proving no difference exists. The power of the Pareca pooled analysis was that by combining data across multiple trials and 3 different drugs, they massively increased the number of male participants in the analysis.
Giving them more statistical power.
Right, enough power to potentially reveal this more subtle but statistically significant difference in efficacy that the individual underpowered trials likely missed.
Okay, that distinction is really key. Underpowered trials versus a more powerful pooled analysis. So that's the nuanced picture for acute Gepant use. What about when Gepants are used for prevention? You mentioned atogepant and rimegepant are used that way. Do they show the same sex difference, or do they behave more like the MABs?
Interestingly, for prevention, the Gepant pants seem to show a much more consistent effect across the sexes, more like the MABs.
Really? So the difference is mainly in acute treatment?
It appears so. For atogepant, pooled analyses of its big phase 3 prevention trials showed comparable reductions in monthly migraine days for both men and women. And for rimegepant used preventively, real-world surveys have reported similar rates of achieving like a moderate or significant reduction in headache days between male and female users.
Okay, so let me see if I've got this right. For Gepants, acute use might be significantly more effective for women than men based on that powerful pooled analysis. But preventive use seems comparably effective for both sexes, much like the MABs.
That's a great summary of the current evidence, yes. This dual pattern is really fascinating.
It suggests maybe different things are happening or different aspects of the CGRP pathway are being targeted in an acute attack versus ongoing prevention.
That's certainly a possibility. The underlying mechanisms might differ between stopping an attack in progress versus preventing attacks from starting in the first place.
This brings up some other really practical questions for you, our listener. If the drugs work differently, maybe our bodies handle them differently, or maybe the side effects are different. Let's talk pharmacokinetics, PK, how the body absorbs, distributes, metabolizes, eliminates these drugs. Are there sex differences there?
That's a critical piece of the puzzle. Let's start with the MABs. Those large population PK analyses we mentioned, they consistently show that patient sex just doesn't have a clinically significant effect on drug exposure for any of the 4.
So men and women basically end up with similar levels of the MAB drug in their system.
Pretty much, yes. No need for sex-specific dosing or anything like that.
Okay, what about the Gepants? They're small molecules. Sometimes those are handled differently by men and women.
You might expect that, but actually, dedicated PK studies for the Gepants have also generally concluded that their disposition, how the body handles them, isn't meaningfully affected by patient sex either.
So for both MABs and Gepants, men and women process the drugs similarly.
Broadly speaking, yes. The PK appears comparable across sexes for both classes.
Now that's really interesting, isn't it?
Right.
Because if the drug levels are similar,
Exactly. It means the difference in efficacy we see, particularly with acute Gepants, likely isn't because men are getting less drug or clearing it faster.
it's not a PK issue.
Right. This is what we'd call a critical negative finding. The lack of significant PK differences really points towards pharmacodynamic differences.
Meaning how the drug interacts with the body's systems at the target site.
Precisely. How the drug interacts with the CGRP pathway within the distinct physiological environments of males and females, especially during that acute migraine attack phase. It brings us right back to that idea of sex-dimorphic pathophysiology.
Okay, that makes a lot of sense. What about safety and tolerability? Do men and women experience side effects differently?
For the MABs, the most common thing you hear about is injection site reactions, mild stuff usually. But overall, the safety profile is considered comparable across sexes. Nothing major stands out.
Gepants?
Gepants are generally pretty well tolerated too. Common side effects might include things like nausea or maybe some fatigue, somnolence. But again, when they've looked at pooled safety data, they've generally found no meaningful differences in safety or tolerability based on sex.
So similar PK, similar safety profiles, but that divergence in acute Gepant efficacy remains.
Yes. And taken together, it really strengthens the argument that the difference isn't about the drug itself being handled differently, but about how it interacts with the underlying biology of the migraine attack, which seems to differ between sexes, especially in that acute phase.
So let's pull this all together. What does this mean for you listening right now, whether you have migraines, know someone who does, or you're a clinician? How do we use this information? It seems like we have sort of a tale of two paradigms here, depending on whether we're talking prevention or acute treatment.
That's a good way to put it.
For preventive therapy, the message seems pretty clear, right?
Yeah, I think so. Clinicians can feel, pretty confident prescribing either the anti-CGRP MABs or the preventive Gepants to both men and women, expecting broadly comparable efficacy. They seem to offer a consistent benefit there.
Okay. But then for acute therapy, using Gepants to stop an attack, it's more nuanced.
Definitely more nuanced. Gepants are clearly a very effective and excellent option for women for acute treatment. The data strongly supports that. For men, well, it's not that they don't work at all for any individual man. Some men might get good relief. But clinicians and patients, too, should probably be aware of that pooled analysis suggesting a potentially blunted or, on average, non-significant effect compared to placebo.
So it might mean tempering expectations slightly for male patients starting an acute Gepant.
Perhaps. Or maybe being quicker to consider switching to a different class of acute medication, like a triptan or something else, if the response isn't optimal after a fair trial. It's about informed decision-making.
Right. And you touched on something earlier that feels really important here.
Yeah.
The elephant in the room, as you called it. The lack of men in these trials.
Yes, it's a huge issue. This profound bias towards female participants, 80 to 90% in most pivotal trials.
Which reflects prevalence.
Yeah. But it creates this massive statistical challenge. You end up with these relatively small cohorts of men. And as we discussed, those small numbers often just don't give you enough statistical power to say definitively whether a drug works or how well it works, specifically in men.
Leading to that lack of evidence of effect not being the same as evidence of no effect.
Exactly. It leaves us with an evidence base that's skewed and potentially less informative about treatment effects in men.
And it probably means these sex-based analyses we're discussing were often done after the fact, not planned up front as key goals of the studies.
That's generally been the case, yes. They're often secondary or post-hoc analyses, not pre-specified primary endpoints, designed with enough power for robust conclusions about sex differences.
So what are the bigger implications here? How does this push us forward?
Well, it has really significant implications for clinical practice, pushing us towards more personalized or precision medicine. It forces us to move beyond a simple one-size-fits-all approach. We need to start considering patient sex as a fundamental biological variable that might actually predict who responds best to which treatment, especially for acute migraine.
And looking ahead, what kind of research do we need to really nail this down and improve care?
Several key things. First, clinical trial design. Future trials, particularly for acute treatments, absolutely must be designed and powered from the outset to allow for meaningful sex-based analysis.
How do you do that? Enroll more men somehow.
That's one way. Maybe using stratified randomization to ensure balance, or even specific strategies to enrich enrollment of male participants so the numbers are statistically adequate. And regulatory agencies like the FDA, EMA, they should probably strongly consider making the reporting of sex-disaggregated efficacy and safety data just a standard mandatory part of the process.
Make it routine, not an afterthought. Makes sense. What else?
We need more clinical studies beyond the initial registration trials. Things like head-to-head trials directly comparing different therapies, maybe MABs versus Gepants or Gepants versus triptans, with patient sex included as a key factor they're looking at. And also large-scale, prospective, real-world evidence studies. We need to track how these drugs perform in diverse populations outside the controlled trial setting, specifically looking at sex-specific outcomes.
And what about the basic science? Understanding the why.
Absolutely crucial. We need basic and translational science to really figure out the precise molecular mechanisms behind that estrogen CGRP interaction in females. But just as importantly, maybe even more so now, we need research focused on male-specific migraine pathways. If the CGRP pathway is potentially less dominant in men during acute attacks, what is driving it?
Finding other targets that might be more relevant for men.
Exactly. That could lead to completely novel therapeutic targets specifically for men, paving the way for truly personalized migraine treatments based on sex-specific biology.
So wrapping this deep dive up, the core insight seems to be that migraine itself is fundamentally different between the sexes. This concept of sexual dimorphism is real. And while these CGRP therapies are a massive step forward, their effectiveness, especially for stopping an acute attack, might actually vary based on biological sex.
That's the crux of it. It's a powerful reminder of how much our underlying biology matters. And it leaves us with a pretty provocative thought, doesn't it? What if really digging into and understanding these subtle but potentially profound biological differences between sexes is the key? The key to unlocking even more effective, truly tailored treatments, not just for migraine, but potentially across all of medicine. This deep dive really highlights both the incredible complexity we're dealing with, but also the incredible opportunity that lies within truly personalized care.
It's fascinating stuff, seeing how this research really pushes the boundaries, aiming for better, more tailored care for absolutely everyone. Definitely food for thought.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.